Okay, good morning, everyone. It's 6:30 Monday morning, and we are here to discuss again a very important topic. I think I'm so happy that we are discussing very rare topics which we will not be able to discuss otherwise. That what should be the role of palliative care physician in patient in children or in adults with the intellectual disabilities. And this topic, I think the best person around is Dr. Jayita. Dr. Jayita is heading the Department of Palliative Medicine at TMH Mumbai. I request Dr. Jayita to take over and introduce the speaker and go ahead. Thank you, Dr. Jayita.
Thank you, Sushma ma'am, and good morning everyone to the IAPC online series to present this topic of palliative care needs of adults with intellectual disabilities. We have Dr. Isha Shah. She's our second year resident doing MD Palliative Medicine in Tata Memorial Hospital, Mumbai. Her areas of interest are oncological palliative care, pediatric palliative care, as well as psycho-oncology. And she recently won the second place for the poster presentation on day 2 at IAPCON 2023 for her work on outcome of advanced cancer patients referred for specialist palliative care in the emergency department. Otherwise, for all these are her academic skills, but you should know that Isha is an extremely empathic clinician and with great interpersonal and interprofessional relationships. And all of us with any sort of problem, our go-to person is Isha for emotional support. So isn't she one suited for psycho-oncology? So Isha will be presenting her talk, and we will have some time for discussion at the end, requesting you to please put your questions on the chat, and we will get on there. So over to you, Isha.
Thank you, ma'am, for the kind introduction. Good morning, everyone. I would like to share my Is my screen visible, ma'am?
Yes, visible.
Good morning, everyone. The topic for today's presentation is palliative care needs of adults with intellectual disabilities. Introduction. People with intellectual disabilities have increasing longevity nowadays as the risk of life-limiting diseases such as cancer increases with age. It could be speculated that more people with ID may require palliative care. In defining intellectual disabilities, the importance of the premise that people with intellectual disabilities are people first. It focuses on what people can do with support if necessary, rather than what they cannot do. Prevalence: approximately 1 to 3% of the global population has an intellectual disability, as many as 200 million people. Intellectual disabilities is significantly more common in low-income countries, 16.41 in 1,000 people. The United Nations Development Programme estimates that 80% of all people with disabilities live in low-income countries. While people with disabilities represent approximately 1 in 10 people worldwide, there are 1 in 5 of the world's poorest people. Definition: what is intellectual disability? First, we see the ICD-11 proposes replacing the word mental retardation with intellectual development disorder. This is the term we use nowadays, IDD, and it is defined as a group of developmental conditions characterized by a significant impairment of cognition functions, which are associated with limitations of learning, adaptive behavior, and skills. It is included under the parent category of neurodevelopment disorders. The disorders of intellectual development are a group of etiologically diverse conditions originating during the developmental period, characterized by the significant below average intellectual functioning and adaptive behavior. Both of these are its components that are approximately two or more standard deviations below the mean. The diagnostic requirements are the presence of significant limitations in intellectual functioning across various domains, such as perceptual reasoning, working memory, processing speed, verbal comprehension. Of all four of this, the performance should be measured using appropriate normed standard tests and found to be approximately two or greater than two standard deviations below the mean. When no such tests are available, clinical judgment based on evidence is used. For the presence of significant limitations in adaptive behavior includes the skills that are performed by people in their everyday lives, which include conceptual skills, like which require knowledge application, like reading, writing, calculating, solving problems. Social skills, which include managing interpersonal interactions and relationships. Practical skills, which include self care, health and safety, occupational skills, recreation and skills, use of money, etc. The onset of all of this should occur in developmental period. The DSM-5 defines intellectual disabilities as a neurodevelopmental disorder that begins in childhood and are characterized by intellectual disabilities as well as difficulties in conceptual, social, and practical areas of living. The DSM-5 diagnosis of intellectual disabilities requires the satisfaction of these three criteria: deficits in intellectual functioning, which includes reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience, confirmed by the clinical evaluation and individualized standard IQ testing. Deficits in adaptive functioning that significantly hamper conforming to developmental and socio-cultural standards for the individual's independence and ability to meet their social responsibility. The onset of these deficits should be during childhood. The advantages of DSM-5 over the new latest criteria over the DSM-4 are that 5 is a more comprehensive overview about an individual. It abandoned the specific IQ scores as diagnostic criteria. It pays more emphasis on the adaptive functioning and the performance of usual life skills. It includes the impairment in one or more subordinate skill domains, which that includes the conceptual, social, and practical areas of living. The AAID, that is the American Association in Intellectual and Developmental Disabilities, that defines intellectual disability as a condition which is characterized by significant limitations in both intellectual functioning and adaptive behavior. We have already seen what intellectual functioning and adaptive behavior stands for. The pattern. Now let us move forward to the patterns of morbidity and mortality. An insight into the patterns of morbidity and mortality among people with ID may provide some indication of the potential palliative care needs in this client group. Death from age-related conditions have shown a progressive increase in this group. Cancer deaths has increased dramatically, and most common being gastrointestinal cancers. Respiratory and cardiovascular diseases were the primary causes of death. All of these are related to institutionalized population, not the community, hence further studies are warranted. The healthcare needs and the healthcare provision. A number of studies incorporated a medical assessment of people with intellectual disabilities combined with a review of their contact and primary healthcare services to determine whether their medical needs were being met. They consistently found a high level of previously diagnosed and unmanaged health problems. Some of them were serious. Special attention needs to be given to this vulnerable client group, preferably through health screening programs. It is suggested that people with ID who don't have an access to palliative screening programs needs to be assessed. Studies also exposed a predisposition against invasive treatments due to issues around the informed consent. There may be socially They may be socially clumsy and misread social situations, which could lead to healthcare staff to adopt the negative attitudes. All this should be looked upon. The physical needs of people with ID include hydration, nutrition, oral and skin care, infection and wound care, including symptoms like pain and others like nausea, vomiting, constipation management, including the overall physical functioning, carrying out the daily activities. They might also require help. Psychosocial needs include the need for societal networking. They need a strong family support, an accepting environment. They require emotional identification and sharing conversations. The experience and presentation of symptoms. Few case studies indicate that symptoms of terminal illness may not be recognized in people with ID. The diagnosis was promoted by objectively observable skills rather than spontaneous complaints. Symptoms are just tolerated or expressed atypically as irritability, inactivity, loss of appetite, or sleep problems. The diagnosis and intervention requires knowledge of specific risk factors and atypical presentations of routine diagnostic screening. Reporting of verbal and behavioral responses to injury and illness accidents that could be expected to be painful are seen in studies, and it was found that 25% had significantly elevated brain thresholds. Those with more severe disabilities are more likely to display less painful behaviors. The possible display of hyperactive behavior rather than pain behavior to indicate the medical need in some patients. These individuals risk significantly delayed reporting of illness and avoidable death, particularly because healthcare professionals often assume the level of pain behavior is indicative of medical need. Self injurious behavior could be an indication of pain or discomfort in people with severe intellectual disabilities. The need is emerging for an appropriate symptom assessment tool for people with ID who cannot communicate pain verbally. Some of these tools are DISDAT. It stands for Disability Distress Assessment Tool. It aims to identify the distress cues in people with cognitive impairment or physical illness or those who have severely limited communication. It is designed to describe the patient's usual context cues and behaviors, thus enabling the distress cues to be identified more clearly. The known triggers of distress are also noted here. So basically, with this tool, we can come to know about what are the normal appearance, vocal signs, habits, and mannerisms of people with ID, and what will be when they will be distressed. Therefore, aiding to early identification of symptoms. Next scale is REPOS, which is the Rotterdam Elderly Pain Observation Scale. It has 10 items, which includes a tense face, squeezed eyes, raising upper lips, grimace, frightening and fearful look, moving body parts, panic attacks, moaning and groaning, sounds of restlessness, verbal expressions, breath holding, etc. 2 minutes of observation is required, and then we have to mark a yes or a no. In repos, if we have greater than three criteria fulfilled, and on the numerical rating scale, NRS, we have greater than 4, it suggests of pain and any intervention is to be required for this symptom. The Abbott pain scale, it has 6 questions which include vocalization, facial expression, change in body language, behavioral change, physiological change, and physical changes. A score from 0 to 6 is given, where 0 to 2 is no pain, 3 to 7 is mild, 8 to 13 is moderate, and 14 plus is severe. The conceptualization of illness and death for people with intellectual disability is in coping with terminal illness, it can be speculated that the way in which illness and impending death is understood is important. Researchers found a marked tendency to relate to illness in terms of descriptions of observable symptoms and behavior rather than explanation of its cause. There was also a fatalistic division of illness into those from which one always recovered and those, such as cancer, from which always died. So researchers concluded that in order to reduce anxiety, it is useful to explain the likely symptomatic course of an illness to an ill patient with ID. Several studies showed that there is a clear link between participants' IQ and the level of comprehension of death. Information giving and honest communication should be done with people of ID. Advanced care planning discussions can be started gradually at each family visits. The training needs, they found that educational needs centered on understanding ID and its importance on social competence, assessment of pain and alternatives, communication systems. Studies suggested limited awareness of the healthcare needs of people with ID among practitioners of primary healthcare teams. Training needs of ID carers include knowledge of terminal illness, practical help, and advice to enhance their health surveillance role, psychological support to manage their own feelings of fear and anxiety, and advice regarding breaking bad news. Palliative care professionals need to develop more effective diagnostic tools for people with ID and understanding of ID services and skills in communicating with people with ID. The need of both ID and palliative care services to collaborate has also been highlighted. There was a clear need to develop greater understanding of respective roles of specialists in ID and in cancer and palliative care services. Satisfaction with services occurred when there was a good partnership working between the different organizations involved in providing services and a shared knowledge and information. The conceptual model of the facilitators and barriers. Now, this has four main domains: education, communication, collaboration, health, and social care delivery. The, the barriers in education include inadequate palliative care knowledge, training, and experience, absence of protocols, policies, and guidelines. For that, facilitators required are hospice referral knowledge, individual intellectual disability symptom assessment toolkits are required. It should be a multi-layered approach with joint education. Pe- in case of communication, people with intellectual disabilities have inadequate communication skills, and there's often avoidance of death-related conversations. We have to facilitate it by a person centered approach, building compassion, empathy, familiarity, and structured models for breaking bad news. In collaborations, what we often see is lack of awareness and referrals to palliative care leads to needs to a kind of lack in services for people with ID and lack of collaboration to palliative care. Thus, what we facilitation that we require is early involvement of palliative care, regional meetings, links with workers and palliative care teams. Under health and social care delivery, people with ID often face diagnostic overshadowing and late diagnosis. There's lack of community and home care services. We can facilitate it by public health support, especially teamwork and adequate staffing at all ID centers. Other barriers include the lack of understanding of health matters and difficulties in following medical instructions, lack of medical notes and history due to previously fragmented care. We don't have most of the time health records, unfamiliarity of the staff in ordinary healthcare services in dealing with the people with intellectual disabilities, and the large number of professionals involved in community care for people with ID, causing confusion for carers. Areas for future development include people with intellectual disabilities are among the most disadvantaged group in society. There is a lack of empirical data around the palliative care needs of this group. Some of the potential problems to do a study are the late presentation of the illness, difficulty in assessing symptoms, difficulty in understanding the illness and its implications, ethical issues around the decision making and consent to treatment. It is important that the disability is known and understood, and the professionals do not misinterpret the signs and behaviors. At the other end of the spectrum, people with severe and profound intellectual disabilities often have extensive supportive needs. Studies and research on how people with intellectual disabilities express and communicate their symptoms is required, and investigate into the direct understanding and conceptualization of illness and death is required. Special attention is needed to ensure that people with intellectual disabilities have access to healthcare services and are able to communicate their needs. There is a need to develop training for carers and professionals working with intellectual disabilities who require palliative care. There is also a need for information on cancer and dying that is accessible to people with ID. Various innovative resources are currently being developed by practitioners, which will help us in understanding of the palliative care needs of people. End of life care for people with intellectual disabilities. The four main themes that emerged include limited participation, the bias, the dignity and quality of life. People with ID are frequently excluded from decision making regarding end of life. The reasons for this exclusion include challenges with communication and cognition, professional and family bias, lack of focus on emotional and spiritual needs. It was reported that they died in segregated, supported living environments rather than specialist palliative care settings. The guidance for the development of training and professional development relating to people with ID at end of life is required. Increase accessibility to end of life care services for ensuring a respectful and dignified death for all humankind, regardless of disability. The top 10 palliative care, uh, the top 10 tips palliative care clinicians should know about navigating the needs of adults with intellectual disabilities. This is one of the articles in which we have the 10 points given, under which the first includes intellectual disability is a type of disease and not a mental illness. Any assessment of individuals with intellectual disabilities must recognize that limitations often coexist with strengths in a person. Appropriate and personalized support is required. Identify these people with their own values, preferences, and influences. Healthcare practitioners must value and support all the relationship people with intellectual disabilities have, including with their families and caregivers. Recognizing the family and the caregivers as experts, because they are the ones who are spending most of the time with the people with intellectual disabilities, and they can recognize even the slightest change in their behaviors. Therefore, incorporating other members also of the family, the caregivers and family members underestimate and overestimate their conceptual of death. They should be helped in identifying such signs. Unconscious bias and discrimination towards individuals with intellectual disabilities contribute to significant health disparities. The poor quality of life is devastating impact on the healthcare provision. Commitment from palliative care teams is required for equalizing the treatment, to work to create cultures of competency, humility, and advocacy along the community side. There are, there are legal safeguards and systems in place regarding decision making in protected patient populations that include people with intellectual disabilities. Intellectual disability people have a fundamental right to education and proper care. Substituted decision making on behalf of people with ID regarding withholding and withdrawing of life sustaining treatments may be an additional legal requirement. People with intellectual disabilities may report or express pain and other symptoms very differently than people without ID, and healthcare practitioners can learn to recognize and assess each person individually. Intellectually disabled people have communication differences and diagnostic overshadowing. Often, their symptoms like pain are under-recognized as their normal behavior, hence they are overshadowed the diagnosis. Comprehensive symptom assessment is required with many toolkits, as we discussed earlier. Collaboration with family members and caregivers to interpret a patient's possible distress behavior. Decisions to disclose bad news to people with ID require careful considerations. Non disclosure of illness approaching death or the illness or death of a significant other may increase distress for some people with ID. What we usually see is families attempt to protect and avoid discussing regarding the illness or end of life. That in turn leads to denying the opportunity for the people with ID to prepare and have meaningful interactions with the significant one who's ill. Therefore, an individually tailored approach is required. We need a more efficient tool, structured models for breaking bad news. When properly supported to understand, many people with ID can engage in two goals of care and EOL conversations. Assumption of lack of comprehension of people with intellectual disability leads to their wishes not being considered. Difficult conversations can be done with the help of interdisciplinary teams, and we can learn to enhance the communication strategies. People with intellectual disabilities face multiple barriers to access equality in palliative care services and end of life care. Lack of collaboration and avoidance of end of life care conversations is what we normally see. There is no one who can make them understand or start the conversation. What we require is educating and giving anticipatory guidance to the caregivers and early involvement of the palliative care teams. Patients with ID benefit tremendously from including the interdisciplinary teams, health cares, and community settings. By partnering the interdisciplinary teams includes the pharmacy, the social workers, the occupational therapists, physiotherapists, speech and language therapy, etc. The positive impact of this interdisciplinary team, such as reduced polypharmacy, increased access to community services, decreased hospital stay, improved well-being, movements and anxiety. Participation in religious and spiritual practices should be allowed. Caregivers and professionals involving in supporting people with ID need training and support in navigating the end of life care. Palliative care and hospice should be discussed with them. Professionals equally benefit from training in ID specific healthcare. The caregivers are often inexperienced and lack training and education. They are unable to identify the signs at end of life. Education needs to be given regarding communication skills, symptom recognition, and caregiver empowerment can be done with the help of training programs and webinars. The consensus norms for palliative care of people with intellectual disabilities. To ensure that there is equity of access, people with intellectual disabilities should have an equity of access to palliative care services and supports that are available in their country. Services and professionals who support people with ID should have access to them. Communication, identification and consideration of needs of people with ID should be done, supporting them to communicate their needs on best possible way, whether verbal or non-verbal. Professional and formal carers have the responsibility to strive to understand them and to seek the necessary training for this. Recognizing the need for palliative care, all health and social care providers need to be able to recognize the situation where the people with intellectual disabilities whom they support need palliative care across the various settings in family setting, institute setting, or community setting. Caregivers should be alert to signs and symptoms of various serious illnesses, end of life, and dying phase. After identification, a person centered plan should be put into place to instigate the palliative care support. Assessment of total needs. The needs of people with intellectual disabilities at end of life include physical needs, emotional needs, social and spiritual needs. All of them should be assessed, documented, addressed, evaluated, and reviewed. They may have special palliative care needs as a result of the presence of the impairment or societal response to the impairment. This should also be recognized and addressed. They should have an equity of access. This includes access to appropriately tailored counseling services and support in maintaining social links, including link with friends who also have special support needs like themselves. Symptom management. Management of symptoms associated with the end of life is of utmost importance. Assessment of pain and other symptoms can be more difficult when people with intellectual disabilities are to be taken into consideration. Symptoms may be masked or expressed in unconventional ways, for example, through behavioral changes, including behavior which may seem as challenging or withdrawal. Professionals should be aware of the possibility of diagnostic overshadowing when symptoms of the physical ill health are attributed to the presence of intellectual disability and therefore not treated or managed. Those who care for a person with intellectual disabilities at the end of life, whether this is a professional or an untrained staff or families, all these persons should be supported in recognizing symptoms including pain. End of life decision making. The end of life decision making is complex. People with intellectual disabilities have the right to life and a right to recognition of value of their lives. A legal framework around the capacity and decision making varies. Professionals should be aware of the national and local laws and regulations and should be adhered to. People with intellectual disabilities should be assumed to have the capacity to make decisions around their care and treatment unless it is demonstrated otherwise and should have all the necessary support, including advocacy, in order to enable the involvement in end of life decision making. Involving those who matter, family, friends, and carers. Their important relationship, that is, the significant others, should be identified and respected. All these significant others could include the family, the partners, friends, carers, including the paid care staff and others. These significant others should be encouraged if they wish to be involved as much as possible at end of life. The person's close carers are likely to know him or her the best as they have been their carers for many years or decades. For people with intellectual disabilities, family bonds may be crucially important at the end of life. This may be the case even where these bonds have been broken due to lack of contact. The person's wishes around involving their families of end of life should be sought and respected. Collaboration Collaboration between services is key to successful provision. Anyone or any service with expertise to offer at end of life should be identified as early as possible in the care pathway and involved in if the need is required. This can include professional service network, paid care staff, informal family carers, and spiritual leaders. It is of crucial importance that people with intellectual disabilities have access to medical and nursing professionals, including support and advice from palliative care experts if needed. Support for family and carers. Families and carers, including the paid or professional care staff, are often deeply affected when someone with intellectual disability reaches end of life, as they are the center of their life, hence often a significant and difficult loss for those around them. They should be supported in their caring role. Preparing for death. Opportunities should be provided to improve people with intellectual disabilities in advanced care planning. This includes discussions and recording of choice regarding the preferences for end of life care, funeral wishes, and wills. Such discussions could take place as early as is appropriate, or they could have place before the need for palliative care arises. Once the need of palliative care has been identified, the carers and professionals should put into place a care plan for anticipating the future holistic needs for treatment and care. The wishes of the person with intellectual disability should be incorporated in this plan. Bereavement support. People with ID experience loss and grief just like the rest of the population, although they may express it differently. People with ID are at a higher risk of complicated grief. Hence, those who support and care for them should be alert of this possibility and aware of any available mainstream and specialist bereavement support services to refer people if necessary. Education and training. Carers and professionals involved in supporting people with ID at end of life should be trained in order to deal with their specific needs. Death education for people with intellectual disabilities. Throughout their lives, people with ID should not be protected from this information and discussions regarding end of life. For example, include sessions at daycare centers or special education facilities, as well as discussions at home, in which all this can be discussed with the people with intellectual disabilities part by part in family meetings. Families and carers should be given help and support in encouraging such discussions, developing and managing services. Policymakers should prioritize equitable care by committing adequate resources to the provision of palliative care for people with intellectual disabilities. Organizations providing care services for people with intellectual disabilities should plan for additional provision of palliative care for them, and vice versa. Organizations who are providing palliative care services should plan for the inclusion of the people with intellectual disabilities among their caseload. This includes planning for adequate space, equipment, staffing, and the provision of expertise. Something that we all need to think about is that 50% of the healthcare professionals who work with people with intellectual disabilities are unable to consult an expert that can help them in identification of symptoms, end of life care, breaking bad news discussion. And 18% of the patients with intellectual disabilities are, are receiving palliative care only at end of life. These are the numbers in United Nations itself, maybe even lower in our country. Conclusion: we would like to encourage the national associations, key stakeholders, palliative care services, intellectual disability services, and all individual practitioners to examine their own practice and policies and make the changes required in order to meet the needs of people with intellectual disabilities. These were my references. Thank you.
Thank you very much, Isha, for a very, very comprehensive presentation. I know we looked through the literature, both of us, and there were not too many papers. Before we go on to any further discussion, just two clarifications that Dr. Meenakshi pointed out. It's Abbott pain scale and not Abbott. And also, when you said United Nations, it's United States, that some of those figures are arising from, and the better kind of services are available in United Kingdom. People have, there is some evidence, but of course, the overwhelming message is that we need to do so much more. A few things to just reiterate. You saw from Isha's presentation, there's a lot of repetitions and reiterations, because those are the important things that we need to work on and make some plans for the future. So till we have some questions on the chat, we have some time for discussion. The first thing I really liked when Nisha said that we have to consider people with intellectual disabilities, not patients, people with intellectual disabilities as persons first. So that means they are their own selves. They will be worried about their own illness and whatever adverse experience. And for them, what is also very important is the other's illness and death experience, because they are mainly dependent on somebody, a parent or another family carer. So anything happening to that family carer affects them a lot, and we have to consider this. The definitions we have seen, we have to focus on the term intellectual disability disorder or intellectual disability, because in some groups people still talk about mental retardation, and that's not acceptable. So it is intellectual disabilities. We have to know that for the definition, two things are important. It's not just the IQ, and it is also about adaptive behavior. And to simplify things, DSM-5 has now got rid of the actual testing scores, and it can be a clinical judgment. The last slide gave us the needs that we have. So the onus is on us that we actually do not identify the needs because we are not trained and we do not have enough of our communication skills to talk to people with adults with intellectual disabilities and their carers. So that is definitely a challenge. And we have to know that they have needs, and we have seen what kinds of needs they have. And to identify the needs, there are some tools that Isha described. The barriers actually give us a clue to the facilitators, and considering that, we can have the models, and that is where the consensus document took the models from. And you can see, if you read the consensus paper as well as the top 10 tips palliative care clinician needs, it really just blends so well with each other. So these are and the last thing that everybody should be involved in, especially for people with intellectual disabilities. It's a lot with the carers and the family, as well as the carers in the system. I know this overwhelming thing was this for me when we went through it. It was about not too many papers, and more about the healthcare providers training needs, and more about communication challenges to understand and discuss about their illness as well as end of life care. So in case anybody else has any questions, you can please put on the chat or we can discuss.
Anybody wants to have any comments on this topic? So Jayita, actually I'm not expecting too many comments on this topic, because this is a difficult area, and we all think that this is challenging to take care of a person with intellectual disability. We all know it is equally important to understand this, as you said, that caregivers distress. Uh, but I don't think that anyone must have given any, as a palliative care physicians, what exactly what exactly extra things which they must be knowing. I think today was the day when Isha explained, and I think this was again a important information she has given to everyone, that these patients also needs attention from ours. If you are having palliative care department, and if your hospital is also catering such people, you should integrate your services. And if these in any of the centers where these people are getting looked after, I think there should be a good integration of palliative care. That's what I can say, Jayata. Dr. Stanley, you want to say something? Go ahead, please.
Yeah. Thank you, Isha, for that very detailed and comprehensive presentation. In your last slide, you mentioned we need to examine our practice. And I think people with disability, intellectual disability, how we care for them, they're a good mirror to view how our care is, because everything that we talk about palliative care, we can see how best we are doing in such kind of patients, because it is totally person oriented, first of all. Second, it is holistic, because it is very difficult to differentiate total, pain from other distress. So we are always looking at total pain. There has to be good team effort, because you may miss something, but somebody in the team who is, well trained, he or she can pick up certain things. Again, the family support, because for the families, these people are very precious, they have been taking care of them all their life, So they recognize small things. And, when we join with them, and also especially for the end of life, when we empower them, then, we have made a lot of grounds. Otherwise we are, getting into too much of details. And the other thing is I want to emphasize is what do you call, the compassionate care. We have to be always sensitive about feelings. All these people, though they have this kind of disability, even the dementias, they have feelings. And they feel how when they are neglected, or when we have explained things to them. And one thing I remember from teachers who have taught me is, people may not remember the details of how you explain things to them, but they will remember how you explained it to them. So, that all emphasizes the feelings part of it. And also you finally mentioned bereavement. Again, it's a very, very neglected area generally. So when we use this as a mirror, it is really help us to challenge us, as Dr. Sushma and Dr. Jayati were saying. Thank you.
Thank you, sir. I think we don't have any further questions. We had a good summary. Dr. Isha's presentation has all the references. So we will put that on the group. Sarchana puts it usually. So thank you very much, and lovely to have been here, and we'll continue with the series. Thank you, ma'am, so much. Thank you.
Thank you, ma'am. Thank you, everyone.
Thank you, Isha, and thank you, Jayita. And thank you, everyone, for joining. And we will see you next week on Monday before 6:30. Thank you, Nisha, and thank you, Archana. Thank you very much.